Hello, friends and colleagues, and welcome to episode 94 of Dermosphere, the podcast by dermatologists, for dermatologists, and for the dermatologically curious. I am one of your hosts. My name is Luke Johnson. I'm a pediatric dermatologist and general dermatologist with the University of Utah. And joining me is...
This is Michelle Tarbox. I'm an associate professor of dermatology and dermatopathology at Texas Tech University Health Sciences Center in beautiful, sunny Lubbock, Texas.
Also joining us, of course, is the Pimping Bell. The Pimping Bell makes a noise like that and exists to highlight especially question-worthy content. For those of you who might not know, in the world of medicine, if you ask a question of one of your learners, that is referred to as pimping them. I guess Pimping Bell might seem like a weird name if you were unaware of that particular tidbit. Also, we are still supported by Hawaii Derm. Thank you very much to the Hawaii Dermatology Seminar for supporting the podcast. The 45th annual Hawaii Dermatology Seminar is coming up this upcoming February 2023, February 19th through the 24th in Honolulu. You want to come join your colleagues there, and you can join us there too. We're going to have a booth there. So thanks to Hawaii Derm for giving us a booth on top of it all. And in addition to being able to say hi to us, you can discover advancements in all kinds of things in dermatology: psoriasis, hair, atopic dermatitis, facial rejuvenation, cutaneous malignancies, and more.
So if that sounds like fun, you want to register today with the exclusive discount code DERMASPHERE, capital DERMASPHERE, to receive 40% off your pass, but only for a limited time. You don't want to miss out on this innovative event. Luke, I'm so excited to have a discount code. I feel very legitimate.
Yeah, and a booth. Two things I've never had before. Still don't know what's going to go on with the booth, but we'll probably have some pens or something, and would love to say hi to you guys.
So today we have some fascinating articles. We're going to start out with a lovely case report that's out of JAD Case Reports entitled Dupilumab in Acquired Perforating Dermatosis, a Potential New Treatment. This is by authors Mused M. Alisabail and Saud Alobaida. I think I said that right. They are out of the institutions. Hold on. I've got my little paper flipped over. My apologies. I cannot find their institutions, Luke. Can you? Oh, sorry. They are from the King Faisal Specialist Hospital and Research Center in Saudi Arabia. And we're very excited to review this. So they go over the acquired perforating dermatoses first. This is an umbrella term encompassing several disease entities, all characterized by transepidermal elimination of dermal connective tissue through the epidermis. So that is the general definition of an acquired perforating dermatosis. These may include reactive perforating collagenesis, elastosis perforans serpiginosa, and perforating folliculitis. There's a lot of different nomenclature that's been used historically for these conditions, including Curley's disease and acquired reactive perforating collagenesis. The etiopathogenesis of these conditions is not completely understood, but it's thought that there is some kind of connection between several factors, including chronic physical trauma through scratching, reduced blood supply potentially because of diabetes and microvascular damage, and overexpression of transforming growth factor beta 3, along with potentially elevated serum and tissue levels of fibronectin as the main culprits.
So,
and diabetes. Go ahead.
I was going to say, I remember these, like the skin has got other stuff in it that it's trying to shoot out. Shoot is probably the wrong word. We don't shoot things out of our skin, but it's like slowly trying to push this collagen out of the top surface because it knows the collagen is not supposed to be right in the dermis there.
Well, and I think that often it occurs under settings where the collagen may be enzymatically or metabolically altered. So we know that sometimes this is going to be more prevalent in patients with things like diabetes mellitus or chronic kidney disease, which may cause modification of some of the proteins, and it might make them more antigenically active. Regardless of the exact etiopathogenesis, what ends up happening is that you have some type of connective tissue that gets sort of eliminated through a transepidermal elimination pore, often associated with some degree of itching and often crusting, scaling, and sometimes even discharge or bleeding. So these are things that can be very disruptive to a patient's life. These things can also occur in the setting of liver disease, hypothyroidism, and HIV. As you know, Dupilumab is a fully monoclonal human antibody targeting the alpha subunit of the IL-4 receptor, so IL-4RA. That's a nice pimping question. This blockade leads to the blockade of signaling through IL-4 and IL-13, and that leads to the inhibition of the Th2 response. So the T helper 2 response can be inhibited. It's been approved for several Th2 inflammatory conditions, including moderate to severe atopic dermatitis, asthma, and chronic rhinosinusitis. Acquired perforating dermatoses have been very difficult to treat, I think partially because they tend to occur in patients who are otherwise medically complex: chronic kidney disease, bad diabetes, liver failure, HIV, hypothyroidism, things that usually require multiple other kinds of medications to manage, and also conditions where often big suppressive medications may be complicating in the management of those patients. The most commonly used medications to treat acquired perforating dermatoses have included topical steroids and antihistamines, which generally, in my experience, aren't terribly effective for this condition. Keratolytics are sometimes utilized. Sometimes when it's severe, systemic steroids, intralesional steroids, retinoids, doxycycline, allopurinol, narrowband UVB, all of these have been used with some success in some of these patients. But if you've ever treated a patient with a perforating disorder, you know how maddening it can be to kind of get these conditions under control. In a recent study, Dupilumab was reported to treat acquired perforating dermatosis in 2 patients who also had atopic dermatitis. So they were being treated on label. They were both elderly patients with late onset atopic dermatitis who were treated for the atopic dermatitis with Dupilumab and had subsequent improvement of both their atopic dermatitis and their acquired perforating dermatosis, which they also had. To the author's knowledge, this medication has not been used as monotherapy for the treatment of acquired perforating dermatosis outside of a patient who also had concomitant atopic dermatitis. So here they're presenting a case of a patient who had acquired perforating dermatosis treated with Dupilumab with an excellent response. So this was a 20-year-old woman. She had Wilson disease and was status post-liver transplantation 5 years prior to presentation.
Wilson's disease is that copper-containing one. Too much copper.
Yes, it is. The Kaiser-Fleischer ring that happens around the iris. Yes, it's a lot of fun to remember all of those things from learning in medical school. She presented with severe pruritus over the upper and lower portions of both limbs, and her symptoms were impacting her activities of daily living. She couldn't sleep properly. She was taking oral tacrolimus, 2.5 milligrams every 12 hours, lamivudine, 100 milligrams daily, and prednisone, 20 milligrams daily. Her symptoms had begun 2 months earlier and had only improved slightly after starting prednisone, 30 milligrams daily, with tapering, which had been prescribed by hepatology also for her high liver enzymes. Physical exam revealed multiple hyperpigmented excoriated and umbilicated papules and nodules, which is a typical presentation for an acquired perforating dermatosis. Often these have central keratotic plugs. These can occur on the upper and lower parts of the body. In this patient, they were on the upper and lower portions of both limbs. They spared the face and trunk. Sparing of the face and trunk is relatively consistent for this condition. It especially tends to spare places that are not scratched or not reachable for scratching. The lab reports were unremarkable, except that she had elevated liver function tests, which is not terribly surprising given her background diagnosis. The patient was diagnosed with acquired perforating dermatosis, and the differential diagnosis included things like prurigo nodularis, arthropod bites, hypertrophic lichen planus, things that would be reasonably in the differential. 4-millimeter punch biopsy was taken, and that showed a neutrophilic crust, which is common in acquired perforating dermatoses, along with cellular debris, underlined by acanthosis and a depression in the epidermis. So sort of pit-like depression is relatively common with these acquired perforating dermatoses. A few collagen bundles were noted within the epidermis. Again, that can be seen in these conditions as you have transepidermal elimination of modified connective tissue frequently with these. These findings were consistent with the diagnosis of reactive perforating collagenesis. Traditional immunosuppressive therapy was not advised by her primary physician, so she was started on Dupilumab with the standard dose of 600 milligrams as the starting dose on day 0, then 300 milligrams every 2 weeks. The patient reported complete clearance of her pruritus within 2 weeks, which was very quick for Dupilumab. It can take up to 12 weeks to see improvement in symptoms. We've reviewed articles in previous podcasts about the utilization of phototherapy with the beginning of treatment with Dupilumab to sort of provide a bit of a remittance of the pruritus and a quicker onset of therapeutic efficacy. In that trial with the phototherapy achieved a faster relief from symptoms, but didn't exceed the symptom relief once both patients' populations were completely on dose with the Dupilumab, but it may be a good temporizing measure for those patients. So 2 weeks is pretty fast. Subsequently, her skin lesions started to subside, and at the 10-week follow-up, she was off prednisone and only had post-inflammatory hyperpigmentation with no active lesions, and she had no side effects from the medication. So that's a pretty miraculous course for acquired perforating dermatoses, especially in the setting of chronic liver disease. The perforating dermatoses are a group of disorders that have this transepidermal elimination of dermal connective tissue. It can happen in patients who have inherited a genetic susceptibility to it. It can also be acquired and associated with a metabolic disease of one type or another. Acquired perforating dermatosis is relatively rare. It has that transepidermal elimination of collagen fibers, typically develops later in life. It's been suggested that it's a reactive response to chronic rubbing and repetitive trauma. And this is somewhat supported by the fact that when you control pruritus, the lesions can resolve. The case that was presented in this article shows that the patient's pruritus, probably the result of her underlying liver disease, seemed to be causative, and when the pruritus was relieved, the lesions were able to resolve. A retrospective study showed that in liver disease is the third most commonly associated condition with acquired perforating dermatosis following diabetes mellitus and chronic kidney disease. So those are like the three heavy hitters for this condition. IL-4 and IL-13 act directly on the itch sensory neurons. So I think that that's something important to understand about the pathophysiology of some of the conditions that this medication is able to treat. So the treatment of the itch with this, you have the kind of resolution of this chronic pruritus with IL-4 and IL-13 inhibition. IL-4 also promotes neural hypersensitivity to other factors such as histamine, chloroquine, IL-31, and cytokine thymic stromal lymphopoietin. These are known to be strong pruritogens, and so this is another mechanism by which dupilumab may interfere with pruritic stimuli. The benefit that we've already observed in patients with atopic dermatitis in many trials has kind of borne out the unprecedented efficacy of this drug. It's also very useful for its antipruritic properties that minimizes skin trauma. And in a condition like acquired perforating dermatosis, where repetitive skin trauma is thought to potentially be causative, that can be very beneficial. They have not had any other previous studies that have shown dupilumab as monotherapy for this condition. So I think this is a nice review of how this might be potentially beneficial. Of course, it is a single case report, and it is a relatively remarkable treatment course. So I think that it's something that could be cautiously utilized in other patients under appropriate circumstances.
Dupilumab. There's nothing it can't do. I want to tell you a fable, Michelle.
I love fables.
A fable about AESOP syndrome.
Ooh, now I'm excited.
AESOP syndrome, because I like learning about stuff that could actually save somebody's life. So it's, in fact, the title is AESOP syndrome, a potentially life-saving and early clue to the diagnosis of POEMS syndrome. This is out of Clinics in Dermatology, and the authors include Cedric Lenormand and Dan Lipsker. So to understand this article, you have to understand two acronyms. AESOP, AESOP, not the ancient Greek fabulist, but in fact stands for adenopathy and an extensive skin patch overlying a plasmacytoma. Okay, I'm going to say it again. AESOP. So adenopathy, like swollen lymph nodes, and an extensive skin patch, and all of that stuff is overlying a plasmacytoma, which is like a neoplasm of the bone that's underneath. Okay, and then you also need to understand POEMS syndrome, POEMS. That stands for polyneuropathy, organomegaly, endocrinopathy, M protein, and skin changes. And it's like this funny multi-system syndrome you can have if you have certain myelodysplastic disorders. So POEMS is rare, but it can be life-threatening, and occasionally this AESOP thing can be a clue to its development. Only about 20 cases have been reported of AESOP syndrome. About 40% of those cases meet criteria for POEMS syndrome at diagnosis, and the rest of patients seem to develop POEMS syndrome if the underlying plasmacytoma is untreated. So what you could see is a slowly expanding pink-red patch, usually on the trunk, that slowly evolves to become more atrophic and have visible vasculature. So that's the extensive skin patch part of the AESOP syndrome. So that's like the ES in AESOP, extensive skin patch. There's also apparently a morphia-like variant that can be a little bit more hard to pin down, and it's more brown, more plaque-like, tends to have a peau d'orange appearance, like the skin of an orange. Most common locations are over the ribs, over the sternum, over the scapula, over the vertebrae, over the clavicle, or over the skull. So this is usually like waist up. And remember, it's the plasmacytoma in the bone that's potentially really causing the problem here. So those are the sorts of bones that tend to get these plasmacytomas. Usually this happens in men. The average age, according to the article, it said 16, but I think that was actually a typo because there was a 2019 study that said the average age was 46. So I'm 42. I better start watching out for AESOP syndrome. Um, if you do a biopsy of this skin patch, Michelle, I might ask for your help in this one because you're our dermatopathologist. You see usually a capillary proliferation in the dermis, a
Mhm.
mixed dermal cellular infiltrate, and then you can sometimes see abundant mucin, which they call cutaneous mucinous angiomatosis.
Okay.
I guess that's skin
I
plus
like that.
mucin plus blood vessels.
See, there's some conditions where you get sort of reactive mucin laid down with either vascular or adnexal proliferations. So this sounds kind of in line with that.
They said histologically, you might include hemangioma on the diagnosis, and sometimes there's sclerosis, especially with a morphea-like variant. So I think that can cause some confusion diagnostically. So your index of suspicion for AESOP syndrome should be kind of high, which hopefully it will be after hearing this podcast. They think that the underlying plasmacytoma, so remember this neoplasia of plasma cells in the bone, is secreting a bunch of VEGF, vascular endothelial growth factor, that causes these skin changes. And so diagnosis of AESOP syndrome relies on biopsying that bone lesion. If you think you have found AESOP syndrome, really what we need is to irradiate the underlying plasmacytoma, and you want to look for POEMS syndrome. So POEMS syndrome has some criteria. Its mandatory criteria are two, and you need them both. You need polyneuropathy. Remember, that's the P in POEMS. It's usually a sensory motor neuropathy. And you need a monoclonal plasma cell proliferative disorder, which is usually lambda. That's the M protein, I believe, in the POEMS syndrome acronym. Other major criteria, you need at least one is a sclerotic bone lesion, like this one that underlies the AESOP patch. You could have elevated VEGF found in your blood, or you can have Castleman disease. Castleman disease comes up every so often in dermatology. I don't really remember what it is, except that it's again some like vaguely kind of lymphoma thing. But I looked it up. It says it's a lymphoproliferative disorder characterized by lymph node enlargement, characteristic features on microscopic analysis of the enlarged lymph node tissue, and a range of symptoms and clinical findings. So apparently, this POEMS is part of the range. And then minor criteria for POEMS, there's a whole bunch of things you can get. Organomegaly, which includes enlarged liver, enlarged spleen, or just enlarged lymph nodes. Remember, in the ESOP syndrome, just lymphadenopathy under that skin patch can be part of it. You can get extravascular volume overload. You can get endocrinopathy of any kind: pituitary, thyroid, gonads, parathyroids, adrenals, pancreatic. And then skin changes is the S in POEMS syndrome. The most characteristic is called glomeruloid hemangiomas. I remember learning about
Mhm.
those in residency. As I recall, they look kind of boring. They just look like cherry angiomas. But if you biopsy them, you find a pattern that looks like the glomeruli and the nephron in the kidney. Is that right?
That's correct.
That's why they're called glomeruloid hemangiomas. That's like a histologic description.
Mhm.
That happens in about 47% of people. Other skin changes you can get with POEMS syndrome include hyperpigmentation in 47%. This is in decreasing frequency. Hypertrichosis, 38%. Acrocyanosis, 34%. Leukonychia, one of my nicknames, 30%. Sclerodermoid changes in 30%. Raynaud's phenomenon in 20%. Hyperemia or erythema in 20%. Flushing in 16%. Rubor in 11%. And clubbing in 6%. Other things you can get with POEMS are papilledema. Remember, that's if you look at the fundus in the eyeball, and then they can have some abnormalities of their other blood cell lines, including thrombocytosis and polycythemia. So you want to look for all that stuff, which is like a lot of stuff. So if you do suspect this, they say X-ray of the underlying bone can be a decent starting point, but really you want a whole body MRI or a PET CT, and then to look for all this other junk, you got to do things like bone marrow biopsy. Well, I mean, you don't, but you should get the patient in to get a bone marrow biopsy. CBC, a CMP, a fasting one, so you can check their glucose, because remember, endocrinopathy, diabetes, calcium, PTH, SPEP, UPEP, thyroid function studies, light chain assay, the sort of gonadal endocrinopathy studies, depending if you're a man or a woman, for testosterone, FSH, and LH, hemoglobin A1C, prolactin, serum VEGF, ACTH with concentropin stimulation, again, looking for all of those endocrinopathies and things. And on physical exam, you want to look for neuropathy, and look in their eyes for that papilledema. You want to look for the lymphadenopathy, hepatosplenomegaly, signs of extravascular volume overload. There's lots to look for. So this POEMS syndrome can be polymorphic, it sounds like. But this AESOP syndrome can be a clue to its diagnosis. And if you do find it, you could potentially save somebody's life, because POEMS can be life threatening. They do report that there's a couple cases of this AESOP syndrome thing overlying something that's not a plasmacytoma. So there was one report of basically the same thing overlying a Ewing sarcoma of the sternum. So that's another like bone neoplasia. And there's another report of it overlying a neoplasm in the muscle, an anaplastic lymphoma in the pectoralis major muscle. And they say, that's okay. If you want to split hairs, AESOP, the P could stand for proliferation instead of plasmacytoma. So we can still stick with AESOP syndrome. That's the story. Who knows if I'll ever see it, especially since I see 70% of my patients are kids. But if I do see it, I'll be happy that I read this article. Thanks to Dr. Lipsker, one of the authors, for bringing it to our attention. We discussed another of his articles in episode 90 on neutrophilic urticarial dermatosis.
It's a very interesting condition, and POEM syndrome is so fascinating. I think the glomerular hemangiomas maybe are also influenced by that extra VEGF elaboration. It's often increased in patients that have this condition. Histopathologically, they are in the differential for tufted hemangioma, so it's sort of in the blue balls in the dermis differential. The glomeruloid hemangiomas have like a little space in them that's reminiscent of the sort of subcapsular space you'd see in a glomerulus in the kidney, but they can be somewhat difficult to tell apart. I think knowing the attendant abnormalities in the different kinds of organ systems is always very useful to have, but it's a highly testable thing and definitely something you could potentially recognize and save somebody's life with. Very cool.
I can't keep it all straight, of course, but if I see something that looks like this and they've got like other funny stuff, then I'll at least know to look back at this article.
I like this. Speaking of things that could maybe be life-saving, we're going to look now at a very interesting observation from JAMA Dermatology from October of this year. And our authors are Ryan Sakody and Barbara Wilson, and they're out of the Department of Dermatology in the Medical College of Wisconsin in Milwaukee. And here they present cutaneous herpetiform ulcerations as the presenting sign of an acute aortic occlusion. So this is definitely one of those derm consults that would have you kind of white knuckling it through their admission course because it sounds very complicated. So they had a
I
patient.
don't usually read about aortic occlusions in the dermatology literature.
No, and it's going to get scarier because the patient doesn't have that many risk factors. So this is a woman in her 40s who presented to the emergency department with a 2-week history of abrupt, painful ulcerations of the perineum. She also complained of bilateral lower extremity weakness. She had a history of untreated hypertension and a 7-year pack history of smoking. The dermatology department was consulted, and evaluation revealed numerous grouped scalloped ulcerations in the perianal and infra-abdominal fold and bilateral inguinal creases. And they have a lovely figure of this in the article, which shows kind of what you would expect. So multiple scalloped ulcerations in a grouped pattern. Certainly I could buy that as potentially herpetiform. The understandable concern for sexually transmitted diseases was communicated, and the patient was appropriately tested. There was no evidence of lower extremity modeling or livido. Bilateral lower extremity strength was grossly normal, and she had intact lower extremity pulses. Swab for herpes simplex virus and varicella zoster virus, PCR, was done, bacterial culture was obtained, and she was administered empiric acyclovir, which is reasonable given her presentation, because of concern for primary HSV. So the results from the HSV, varicella zoster virus, polymerase chain reaction, and bacterial culture were all negative. The painful ulcerations progressed and became necrotic during the course of 4 days. Punch biopsies were obtained from the ulcerations on the buttocks and the abdomen, and all specimens demonstrated epidermal necrosis with mild inflammation and some early thrombus formation in the superficial dermal plexus, suggestive of a vasculopathy. So they then did a CT scan of the chest, abdomen, and pelvis on day 6 of her hospitalization, and they were able to observe a completely occluded infrarenal abdominal aorta with substantial calcification at the level of the aortic bifurcation. Her CT scan is pretty scary looking. So looking at her CT scan with contrast, you can see good filling of the thoracic aorta and good filling of her renal arteries, but you do not see anything below those. So the entire abdominal aorta is not perfused, which is why she was developing these strange patches of necrosis. Now, then you might be asking, why did she not have leg weakness? Why did she not have modeling of her lower extremities? And the authors go through a very careful and thoughtful dissection.
How could she still be walking around?
Right, of how this could have possibly happened. So she underwent an aortoiliac bypass and was started on systemic anticoagulation. No deep vein thromboses or intracardiac thrombus were present. She had no patent foramen ovale or hypercoagulable syndrome. Her abdominal aortic aneurysm or occlusion, was thought to be secondary to thrombosis of an underlying aortic plaque. And at 12 months post-discharge, she was undergoing rehabilitation from subsequent procedures. So in this patient, she had an acute aortic thrombosis, which did present with lower extremity weakness, and then ulcerations of the groin and abdomen. She had a delay in diagnosis because her legs looked so healthy partially. Her lower extremity pulses, remember, were palpable and normal. She didn't have any modeling or any vascular occlusive looking changes in her lower extremity. She did have subjective weakness, but on physical exam, it was relatively normal. So they understandably weren't necessarily worried about devascularization of the lower half of this person's body at her presentation. They think that the reason why her presentation was a little bit occult was that this patient had things that had sort of caused a slow creep of vascular occlusion for her. So she had hypertension and tobacco use, and they suspect that collateral circulation had time to develop in this patient, allowing bypass of the progressively occluded abdominal aorta through systemic or visceral vessels. And that allowed for masking of some of the symptoms because the legs were still getting perfused. So it was just areas of skin that were in the watershed area of the occluded vessels that really took the hit in this patient's presentation. And so her very significant systemic vasculo-occlusive disease really hinged on the diagnosis of why things were happening to her skin. So I think that this, if anybody ever doubts the validity or usefulness of inpatient dermatologic consultation, I know not every consult is this kind of a Hail Mary slam dunk type of situation. But sometimes our input can be very meaningful to patient management. And so I think that those of us that see patients in hospital consultation, I appreciate people doing that for our specialty and for those patients. Acute aortic occlusion is a rarer syndrome. It's usually associated with relatively significant morbidity and mortality. There's acute bilateral leg pain, typically modeling of lower extremities, but as in this patient, that might not always be present. Sensory motor defects can also follow, and paraplegia can occur. The acute aortic occlusion can be caused by thrombosis of an underlying atherosclerotic plaque in more than 3/4 of cases, including in this patient. Cutaneous ulcerations in the perineal area in the setting of acute aortic thrombosis are rare, but there are cases previously reported previously in the literature. Limited cardiovascular risk factors can potentially cause this. So this patient was in her 40s and smoked and had hypertension, but didn't have any other risk factors. So that's not a small percentage of the population could fall into that level of risk. She didn't have any hyperlipidemia, advanced age, diabetes, cancer, hypercoagulable state, or antiphospholipid antibody syndrome. So it should be something you would consider for a patient with acute pain and sterile herpetiform ulcerations in the perineum, even if they don't have a lot of cardiovascular risk factors. And early evaluation with CT may potentially prevent substantial morbidity and mortality. So if you have unusual herpetiform necrotic ulcerations that are sterile, you want to think about vascular occlusion. And the pictures of this made me think of the way that it looks when you have inadvertent intraarterial injection of filler on the face. So if you've ever seen a patient through the evolution of a vascular occlusive event subsequent to filler injection, it looks very much like herpes. Herpes is almost always in the differential for a vascular occlusive event from filler injection. And the appearance is very similar to what they're showing here with this vascular occlusive event following the aortic the abdominal aortic occlusion. So definitely think about vascular occlusive conditions when you have something that looks herpetiform and is necrotic but is sterile without any evidence of viral or bacterial infection.
Pretty scary.
Mm-hmm.
2 weeks of painful herpetiform ulcers in the anogenital area. I mean, I would not jump to aortic occlusion, right? This seems pretty good for herpes. It's also kind of interesting that it was the ulcers, the skin stuff, that brought her to the emergency department. Though she also said she had some lower extremity weakness, but on exam, her lower extremity strength was grossly normal. So gotta be pretty suspicious. I'm reminded, looking at the CT scan, one of our faculty here, Dr. Duffy, said half jokingly to the residents, if you ever submit anything to an article, to a journal, and it's got anything radiographic in it, you got a really good chance of being published. And so, as again, half joke, maybe full joke, one of our residents in his next presentation presented a normal chest x-ray as part of his presentation. All right, I want to talk about something else, also with ulcers, also with emergency rooms, also scary, A little bit more depressing overall. This is out of a journal called Curious, Cureus. We've discussed one or two articles from this journal before. This article is called Xylazine-induced skin ulcers in a person who injects drugs in Philadelphia, Pennsylvania, USA. Authors include Sri Krishna Malayala and Aliyah Wimbush. Sorry if I mispronounced your name. Out of Philadelphia. So xylazine, spelled Xylazine, may not sound familiar to you, unless it sounds a little bit like xylocaine, which is the other name for lidocaine, but this is not that. This is a horse tranquilizer,
What?
veterinary medicine. And apparently it's being added to illicit injectable drugs, primarily in Puerto Rico and Philadelphia, and maybe a few other places like Maryland and Connecticut. And apparently it can cause big, nasty, infection-prone ulcers in the skin in the areas where it is injected. Especially, this isn't exactly the same as skin popping. People are at least trying to inject it into their veins. You still get big old ulcers. And this article is a depressing case report about a woman who had recurrent issues with these old ulcers. She is a 30-something. She was, quote, experiencing homelessness, and she injected a lot of fentanyl mixed with xylazine into the veins of her arms, more than into her legs, and got these big, grody ulcers on the legs, extending from the knees to the ankle with copious, purulent, malodorous drainage. The ulcers extended to the bone in some places. She had muscle and soft tissue abscesses. She had extensive tissue necrosis, cellulitis, and osteomyelitis as a result of this stuff. She was hospitalized. She was treated with IV antibiotics, and then she left AMA.
Oh
And she
man.
did that numerous times. Finally, on her fifth admission for this same thing, she did stick around for the entire treatment and was discharged to a recovery house. So one can hope, perhaps, that this will end up having a happy ending, but it's hard for me to be particularly optimistic about it. So xylazine, apparently on the streets, is called Trink sometimes,
Oh god.
because it is a horse tranquilizer. And it may be intentionally mixed into drugs to prolong their effects. People might want it mixed with their fentanyl. It's not just like an adulterant, just something to bulk it up, though it can be that as well. Usually it's mixed with fentanyl or heroin to make trank dope. Its local vasoconstrictive effects are thought to cause the ulcers, though if it acts centrally, it's a sympathetic antagonist, decreasing heart rate and contractility. The traditional urine drug screen doesn't pick it up.
Mm.
It was discovered in 1962 in Germany and is an alpha 2 agonist similar to clonidine. And as I said, used in veterinary medicine as a sedative and analgesic. It's kind of
Oof.
depressing to talk about street drug abuse and so on, for a lot of reasons. If you're interested in some of the statistics, the leading drugs associated with overdose deaths have been changing over the years. So again, drugs associated with overdose deaths. Number one was cocaine back in 2000 to 2006. Then from 2007 to 2014, it became prescription opioids. Perhaps that's why we got all this chatter about opioid overprescription. Then 2014 to 2015, it changed to heroin. Hey, maybe all that chatter did something. And then 2016 to present, it has been fentanyl, the drug associated with the most overdose deaths. And xylazine does seem to contribute to these overdose-related deaths.
Yeah, the central, like the cardiac depression associated with it certainly is troublesomely complementary to the suppressive effects of narcotics. So I feel like it's kind of a recipe for disaster. The physical presentation is striking. It actually looks like very severe pyoderma gangrenosum. So I think probably something that needs to be in your differential for that in patients that may be at risk. Marginally housed people tend to have higher rates of substance abuse, which, you know, I can't imagine the burden of trying to live in a circumstance where I had no access to safe places to stay. So I think that there's a lot contributing to the ill health of these people in these situations. But definitely something important to recognize. There's a little bit of a geographic nature to some of the areas of involvement that may potentially be helpful information, but it's pretty severe looking.
So pretty discouraging. What do we do about cases like this? With understanding that these other people are also human beings and in a very different life situation than we are and have a humble, there but for the grace of God go I kind of approach to it. on the other hand, it's hard to help people who don't seem like they want to help themselves and keep leaving the hospital and so on. So there's certainly psychological tension, at least for me, with stuff like this. The authors point out that addiction is challenging. It's a challenging problem to treat. And when people have medical issues like horrible skin infections, they may be apprehensive about seeking healthcare because, well, a lot of reasons. They might fear that they'll be judged. There's social stigma. They have poor economic status. Like, how am I going to pay for this healthcare? They might not have good healthcare awareness. They might have limited access. So, a lot of problems. I don't know what the answers are, but those of you out there practicing addiction medicine, thank you.
I think that housing first programs do a lot of good for patients that have difficult extenuating circumstances like this. I think that there certainly needs to be some element of psychological support as well, because I think a lot of psychiatric comorbidities can, untreated, predispose patients to desperate circumstances like this where there's just not a good solution in sight. So, well, that is a sad thing to think about, but an important thing for us to potentially be aware of as a unique presentation. I'm trying to make a good connection here, and I can't really connect these two entities. Oh, wait, I figured something out. So this is IV use of drugs, yes. So naughty, bad drugs we don't like. Some IV things that we use might be beneficial for patients. So we're going to look now. See, that was a long walk, but we're going to get there.
Right. Instead of injecting horse tranquilizer, inject immunoglobulins.
Other people's immunoglobulins. What could go wrong? So, New England Journal of Medicine article here on a trial of intravenous immunoglobulin in dermatomyositis. The chief authors are Drs. Agrawal and Levine from the ProDerm trial group, and they are out of multiple different institutions. They're going to look at the utilization here of IVIG in the treatment of dermatomyositis. It's not been extensively evaluated. It has been reported anecdotally in the literature. So they wanted to conduct a randomized placebo-controlled trial for patients with active dermatomyositis. The patients were assigned in a 1-to-1 ratio to receive IVIG at a dose of 2 grams per kilogram of body weight or placebo every 4 weeks for 16 weeks. So 4 total treatments of 2 grams per kilogram of body weight. The patients who received placebo and those who had the IVIG without confirmed clinical deterioration could enter the open label extension for another 24 weeks. And that's just like further support for the patients who responded well in the therapeutic arm, and also an opportunity for patients who were assigned to the placebo arm to get active treatment. The primary endpoint was a response defined as total improvement score. So this total improvement score looked at a number of different metrics. It's a weighted composite score that looks at 6 measures of myositis activity over time. The scores range from 0 to 100. Higher scores indicate greater improvement. So 100 would be the best improvement you could get. 0 would be no improvement at all. Their secondary endpoints included at least moderate improvement and then major improvement. So they defined minimal improvement as a score from this total improvement score, the TIS, of 20. So this is minimal improvement. Moderate improvement was 40 and greater, and significant improvement was considered greater than 60. So major or significant improvement. And they looked at the cutaneous dermatomyositis disease area and severity index, which is a specific measure for dermatomyositis in these patients. So they had 95 patients that they randomized. 47 patients were assigned to IVIG, 48 to the placebo group. At 16 weeks, 79% of the patients in the IVIG group and 44% of patients in the placebo group, so the placebo group did pretty well in this intervention, had a total improvement score of at least 20. So the difference there was 35 percentage points with a 95% confidence interval. The results with respect to secondary endpoints, including moderate or major improvement, were in the same direction as for minor improvement, with the exception of change in the creatinine kinase level. So the creatinine kinase level did not differ meaningfully between the two groups, but everything else improved in patients who were treated with IVIG versus patients who were treated with placebo. Over 40 weeks, they found 282 treatment-related adverse events in the IVIG group, including headache, 42% of patients, pyrexia in 19% of patients, and nausea in 16% of patients. Relatively common side effects for an infusible medication like this. 9 serious adverse events were considered to be IVIG related, including 6 thromboembolic events. And the thromboembolic events had enough frequency at the early part of the trial that they actually modified their infusion protocol to slow down the infusion, which decreased the risk of thromboembolism. The reason that they postulated that this was necessary is that patients who have IVIG have multiple reasons why they may be predisposed to thromboembolic phenomenon, and so being cautious in that patient population is reasonable. So in this 16-week trial in these adult patients with dermatomyositis, the percentage of patients with a response of at least minimal improvement based on this composite score of disease activity was greater amongst those who received IVIG than placebo, and IVIG could be associated with thromboembolism as well as other adverse events. The criteria that they used to kind of evaluate the dermatomyositis, I believe we've maybe talked about before. There are these Bohan and Peter criteria that include symmetric proximal muscle weakness, evidence of myositis on muscle biopsy, elevation of serum skeletal muscle enzymes, electromyographic findings consistent with myositis, and a typical rash of dermatomyositis. Concomitant treatment was allowed in this study, so patients were not on monotherapy with IVIG. They were allowed to be treated with a maximum of 2 immunosuppressive drugs that could include glucocorticoids. So the drugs that were allowed were methotrexate, azathioprine, mycophenolate mofetil, sulfasalazine, leflunomide, tacrolimus, cyclosporin, and hydroxychloroquine. So all of those drugs were permitted. They could be in any combination, but a maximum of 2. And they were permitted if treatment had been initiated at least 3 months before enrollment and was at a stable dose, not exceeding maximal allowable doses for at least 4 weeks prior to enrollment. Biologic agents, cyclophosphamide, IVIG, and topical glucocorticoids were not allowed. So they were allowed systemic glucocorticoids, but not topical, and they weren't allowed any biologic, cyclophosphamide, or IVIG prior to the study. No patients received Janus kinase inhibitors. During the open-label extension, the concomitant medication for dermatomyositis could be tapered and stopped at the treating physician's discretion. Myositis disease activity was assessed according to a core set of 6 measures that were designed for the evaluation of myositis, and these were used as the basis of the primary endpoint. This is the Manual Muscle Test 8, a measure of strength in 8 muscles tested bilaterally. Total scores range from 0 to 150, with lower scores indicating weaker muscles. For patients in this study, they were eligible if they had muscle weakness with a score of less than 142 on the Manual Muscle Test 8. So out of 150, they had to have a score of 142 or lower, which would indicate more weakness, to be enrolled. They also looked at the physician's global assessment of disease activity that was assessed on a 10-centimeter visual analog scale, with 0 representing 0 evidence of disease and 10 representing extremely active or severe disease activity. And so the physician's global assessment, they had to have a score of greater than or equal to 2. They also looked at the health assessment questionnaire, where they score in increments of 0.125 from 0 to 3 that tell you how disabled the patient is by their condition. So 0 would be no disability, and 3 would be complete disability. They also looked at extramuscular disease activity on a 10-centimeter visual analog scale, ranging from 0 to 10, with higher scores reflecting more disease in the extramuscular organs, and that could be affected by myositis. Serum muscle enzyme levels, creatinine kinase, alanine, aspartate aminotransferase, and lactate dehydrogenase and aldolase were measured. Patients were eligible for enrollment if they had met some of these criteria. They had to have also the extramuscular disease activity and an HAQ score of greater than 0.25, so some level of disability, and a muscle enzyme level greater than 1.5 times the upper limit of the normal range. Any active rash that can be associated with dermatomyositis, such as heliotrope, gotrons, or other typical dermatomyositis rashes, were not required for inclusion, but all of the patients had a rash. So all of the patients in this dermatology study, which makes sense, that's why we are seeing them, had a rash. Muscle biopsies were not performed as part of the trial. Patients with cancer-associated myositis, overlap syndromes, inclusion body myositis, juvenile dermatomyositis, or drug-induced myopathy or polymyositis were excluded. Patients with hyperviscosity or other hypercoagulable states were prudently excluded because of the risk for thromboembolic phenomenon, which I think was very reasonable and appropriate. So looking over the study, they had a few little tiny hiccups that in the overall assessment didn't seem to affect their data. They actually did have 3 patients who were switched in error from the placebo arm to the IVIG group, but their post-hoc analysis indicated that did not change the reliability of their results. And they did have patients who were switched from the placebo group to the IVIG group because they had confirmed deterioration of their condition. So patients who deteriorated in the placebo group were able to be switched over, which is an ethical way to handle that kind of thing. They also had the potential for the extension phase. The extension was after the randomized controlled portion of the trial, those first 16 weeks, they were able to go forward with continued therapy with the IVIG. And they had 34 patients in the IVIG group and 35 patients in the placebo group that completed the extension phase up to week 40. So a good majority of the patients wanted to continue on therapy, which is often a good indicator that there's therapeutic benefit to the medication. And I think that's always something nice to look at. So the patients had muscle weakness and active disease. Their mean MMT8 score was 120.9. Remember, they had to have less than 142 to be included in the study. Their mean score was about 120. Their mean physician's global assessment disease activity score out of 10 was 5, so about a significant burden of disease. Most patients had at least a mild rash, 83% had a mild rash, and 54% had moderate to severe dermatomyositis rashes. They had a good percentage of patients with moderate to severe disease defined by physician's global assessment, 77% in the IVIG group. The placebo group only had 69% in the moderate to severe group. So it's nice to see that if they have one patient population that has less severe disease, it's nice for that less severe disease population to be in the placebo group. That happened randomly, but it's nice that it wasn't the other way around because it would be harder to interpret the data if that was reversed. 99% of the patients had concomitant therapy for dermatomyositis during the trial. 88% had systemic glucocorticoids, and 68% had non-glucocorticoid medication. The use of concomitant therapy was similar in the 2 trial groups, and most patients had had previous treatment failure with systemic glucocorticoids and at least 1 non-steroidal immunosuppressive medication before enrollment. So these were not the easiest, freshest patients in the world to treat. So for the primary endpoint, we talked about they had 79% of the patients reach that minimal improvement in the treatment group with IVIG versus 44% in the placebo group for a 35% percentage point difference with a 95% confidence interval that is significant. Their total improved score was also looked at with respect to moderate and major improvement, and it went in the same direction as the mild improvement, but it was a little bit less significant. I think that it's a good indicator that there's a dose-response relationship with this, as well as the ability to assess for different variants of severity of disease. They modified, as I said, the infusion rate partway through the trial. They actually lowered the maximum allowable infusion rate from 0.12 to 0.04 milliliters per kilogram per minute after the initial phase of the study showed a little increased rate of the thromboembolic events. And after they made that adjustment, they were able to drop the incidence of thromboembolic events from 1.54 per 100 patient months to 0.54 per 100 patient months. So they were able to make a significant difference by decreasing the rate of infusion, which also makes sense because hyperviscosity of the blood can predispose patients to blood clotting. So in this, I think, very well done trial that had minimal abnormalities in it, they had the 3 patients that got switched on accident to the IVIG arm. They showed well that there was benefit to this intervention and that they had understandable and predictable side effects they could mitigate by altering the infusion rate for these patients. So an option for patients with dermatomyositis. Pathophysiologically, we don't 100% understand how this works, but it's thought that it might help to decrease some of the cytokine activation that happens in the condition.
IVIG is like a bunch of other people's immunoglobulins that are all mixed together and then injected into you.
Mm-hmm.
And the idea, I guess, is that those immunoglobulins fight the bad immunoglobulins that your white cells are producing.
The way I've always understood it is it's almost like a sponge, and it sort of non-specifically sops up the inflammatory milieu mess of an inflammatory condition. So it can be used in things where the immune system is hyperactivated in an inappropriate way. They think that it has to do in dermatomyositis with inhibition of complement consumption and interference with the formation of the membrane attack complex, which are things that have been implicated in dermatomyositis and are considered pertinent because C3 activation in dermatomyositis can lead to the formation and deposition of the membrane attack complex on the endomysial capillaries, and that can cause capillary destruction and microangiopathy, which is thought to be one of the foundational causes of pathology in this condition. So potential therapeutic intervention, a potential modification to make it less risky for the patients, relatively predictable side effect profile. I think well done study overall, and a good review of how to assess patients with dermatomyositis, as well as some therapeutic considerations for this unique patient population.
I've never prescribed IVIG, Michelle.
You haven't?
Plenty of my colleagues have. We've got autoimmune specialists here, and they, I think, often end up taking these more serious cases. But if I'm ever going to, it seems like I should definitely reduce the rate of infusion. Like, that's a kind of a no-brainer that came out of this article, as far as I can tell. Also, like thromboembolic events, how big a deal are those? Well, if you look at the table, there was hypoesthesia, meh. DVT, not great, but if it doesn't progress to PE, then maybe it's not a huge deal. But there were also 2 pulmonary embolisms, a cerebrovascular accident, which is listed differently than the cerebral infarction. So bad things did happen to some of these people. Looking at the table, it's interesting, though. It looks like all of these thromboembolic events were in the open label extension. So in some senses, you can't say for sure that it was the IVIG because there wasn't really a placebo control going on at that time. But the study authors considered it to be related to the IVIG. So it looks like the upshot is if somebody's got bad dermatomyositis, they might just get better a little bit on their own, regression to the mean type stuff maybe. So on a scale of 0 to 100, they get over 16 weeks, they're going to get about 20 points better. If you give them IVIG, they might get 50 points better instead. But there's a small chance they'll have a stroke.
Yeah. And
kind of scary.
Nothing is, of course, a perfect therapeutic, but it's a interesting therapeutic. I've used it for patients with bad pyoderma gangrenosum. Tends to be beneficial for them. I've had a couple of vasculitis patients that I've co-treated with rheumatology that it's been beneficial for, but it's definitely its own animal. And that because it's a pooled immunoglobulin product, it's never the same product twice, right? So that's a little bit of a difference. You also have to be thoughtful about the possibility of selective IgA deficiency in these patients. So when we were using a lot of IVIG for toxic epidermal necrolysis, the question was always, do we wait for the IgA level to come back before we dose the patient? In a condition like this, where it's urgent but not emergent, I think it would be very prudent to check for selective IgA deficiency. There are certain manufacturers of IVIG that don't include a significant fraction of IgA in their product specifically for that reason, but others do include the IgA, and it's per hospital, per pharmacy sometimes. So if you have an urgent need to use the product, I believe it's GammaGuard that doesn't have an IgA fraction that's significant. Checking with your hospital pharmacy about which product is available for your patient may be prudent if you need to use it under an emergent circumstance. Under a circumstance where you can screen for IgA deficiency, I would recommend doing that.
The reason being, if you're one of those rare people who don't make their own IgA, you will probably have an immune response if somebody else's IgA gets into your blood. And of course, no surprise, this study was funded by a pharmaceutical industry that I assume makes the IVIG, Octa Pharmaceutica. Well, I think that's all I've got time for today. Thanks for hanging out with us today, guys. Today, we learned about Dupilumab. There's nothing it can't do, including treating perforating dermatoses. We learned about AESOP syndrome, how it can be a clue to POEMS syndrome. We learned about perineal herpetiform ulcerations, might not be herpes, but could actually be aortic occlusion. We learned that you should not inject horse tranquilizers into your veins. And we learned that IVIG can potentially help with dermatomyositis, but at a bit of a risk of thromboembolic events. Thanks to our institutions. Thanks to the University of Utah for supporting the podcast, and thanks to Texas Tech for lending us Michelle. We've got an increasing team of enthusiastic medical students who are helping us out with the podcast as well. Our team now includes Morgan Dykman, Guy Kusecki, Eleonora Marcacci, Michael Birdsall, Aparna Nayak, Neha Deo, and Haley Walsh. Among other things, they keep our social media accounts moving along. You can find us on Facebook, Instagram, and Twitter. You can also find us on our webpage, dermospherepodcast.com, which also has our entire archive as well as links to all of the original articles. You can also find us on our other podcast.
Our other podcast is called SkinCast. It's a public-facing podcast aimed at lay people who want to learn how to take the very best care of the skin they're in. The episodes are shorter, about 15 to 20 minutes per episode. They typically cover 1 to 2 patient-relevant topics and range from things such as contact dermatitis to hair care to sun protection to diet and acne.
SkinCast has been on a bit of a I was going to say hiatus, which is true, but then I decided I was going to use the term
sabbatical. It's a sabbatical. There you go.
That's what I was going to say. It's been on sabbatical because of some turnover at the University of Utah, but certainly the episodes are still out there, and hopefully it will have a renaissance. Michelle, the next episode is the last episode of 2022. You know what that means.
I've got my party dress ready, Luke.
The Dermy Awards. So at the end of every calendar year, we make up some goofy awards that we give out to some of the articles or authors that we've discussed over the course of the year. The Dermy Awards. Come join us then. You won't want to miss it. And of course, come see us in Hawaii in February as well. Good times should be had by all. We'll see you guys in 2 weeks.